Hello, I am Edwina Borwn. I'm going to be talking about supportive care for the renal patient and concentrating on giving prognosis and coming up with a care plan. There are some key documents to be read, and one of these is an executive summary from a meeting held by Kay Digo, which focused on supportive care in chronic kidney disease. And it gives an excellent summary of what the problems are, how to do it, and a list of references. Another book that I thoroughly recommend reading is by Atul Gawande. He is a surgeon at Harvard and is a medical journalist, and he wrote this book, Being Mortal, which was published a couple of years ago. And in this book he has written, technological society has forgotten what scholars call the dying role and its importance to people as life approaches the end. People want to share memories, pass on wisdoms and keepsakes, settle relationships, establish their legacies, make peace with God. This role is, observers argue, among life's most important for both the dying and those left behind. And this is shown in this wonderful painting by Rembrandt of Jacob blessing the sons of Joseph. In previous generations, people died with their families. They knew they were dying often and passed on wisdom, blessings, information. In our way of managing end of life as a technological exercise, with people in hospital and surrounded by strangers, this is difficult to happen. So let me tell you a story. This is a 78-year-old woman, Greek Cypriot, who was admitted moribund with chest sepsis. She'd had a cardiac arrest 2 hours later and was transferred to the intensive care unit. In the past, she'd had vagueness about 12 years ago, which had been treated with prednisolone and cyclophosphamide. She'd had a cerebral lymphoma 6 years later, treated with radiotherapy, and then an admission 2 years ago with urosepsis, following which she was discharged bedbound with gastric feeding. She was demented related to her cerebrovascular disease and radiotherapy for her lymphoma. Following her cardiac arrest, she was in ITU for 4 weeks, ventilated and on hemofiltration. She was weaned off the ventilator, transferred to a renal ward, but remained dialysis dependent with a Glasgow Coma scale of 4 at best. She was fed by nasogastric tube as her gastrostomy tube was blocked. The family were completely unrealistic and the sons demanded active treatment. Medical team went along with this to avoid antagonism. After 3 weeks on the renal ward, she aspirated, dropped her blood pressure. She was transferred to the high dependency unit and started on noradrenaline. She was turned down by the intensive care unit team, but the sons continued to demand active treatment and the medical team continued to comply with this. She remained on noradrenaline, intravenous antibiotics, and positive airways pressure. She died 3 days later, 1 hour after starting dialysis on the high dependency unit at 5 o'clock in the morning. I want to get you to think about 4 questions. Have you been involved with a similar end-of-life scenario? Is this the death you want for yourself? Is this the death you would have for a loved one? And why do deaths like this continue to happen? Well, I think that there was a failure to communicate the poor prognosis to the family. There was inappropriate prolongation of dying and a failure to resolve the conflict with the family. So during this talk, I'm going to be giving you some tools which will hopefully avoid perpetuating scenarios like this as people are inevitably dying. We're going to talk about the concepts of supportive care, predicting mortality, advanced care planning, and cultural awareness. This is a painting by Cranach, a German Renaissance painter of the 15th century, called The Fountain of Youth. On the left, you can see decrepit, sick people going into this pool, coming out looking young and beautiful. And this is many people's perception of going into hospital, starting dialysis, having any type of major surgery. And unfortunately, it is often also the perception that we as healthcare providers give to our patients. But we all know that medicine isn't like that. So what is supportive care? The definition given by the Palliative Care Council in the UK is that supportive care is care that helps a patient and family to cope with the condition and its treatment, from pre-diagnosis, through diagnosis and treatment, to cure, continuing illness or death, and into bereavement. It helps patients maximize benefits of treatment and to live as well as possible with the effects of disease, and it is as important as diagnosis and treatment. Supportive care can be illustrated in this sort of diagram. It is something that is provided right from the start of diagnosis of a long-term condition. Yes, aggressive treatment is useful and required, but as the illness and the long-term condition progresses, the value of aggressive treatments become less and less. With kidney disease, the aggressive treatments are dialysis, transplant, access surgery, general surgery, antibiotics, and supportive care is pain control, symptom control, psychosocial support, and awareness of the patient's goals and concerns. And this continues into bereavement for the family. So how do we achieve the aims of supportive care? Right? Communication. Communication is absolutely key. And the communication needs to centre on the patient and family expectations and wishes, understanding the symptoms, talking about pain control, and giving a realistic prognosis. Also includes awareness of the patient being at the end of life, advanced care planning, and appropriate management of dialysis, and discussing withdrawal where appropriate, or not starting dialysis. So how do we predict mortality and give prognosis? One of the earliest attempts of doing this was published in 2010 by Lewis Cohen and Mike Germain in C. Jason. And it is based on a model with the surprise question asking, would you be surprised if this patient died in the next 6 months? The age of the patient, the plasma albumin, dementia, and peripheral vascular disease. And what this graph shows you is that the more of these questions that the patient has, then the worse the prognosis and the higher the chance of the patient dying within the next 2 years. This graph also shows that it is not an absolute predictor. And even if you scored on all of the 5 things, as you can see here, 25% of people will still be alive at 2 years. And this uncertainty is what makes some physicians shy away from the issue of talking about prognosis with a patient and the family. There are other ways of assessing prognosis. People on dialysis are the same as general population, and this is a study done by Nancy Kuttner showing that the worse the baseline gait speed, the worse the survival. So again, the bottom line here are people who are not even able to perform a walk test, and again, as you can see, about 50% of them have died within a couple of years. This is a study that was done by Vanita Jassal in Toronto, looking at predictors of death in hospital or discharge to an assisted care facility. And the 3 bars for each age group is looking at those who can perform all their daily activities, and some of them who need assistance with some of their daily activities, and those who need assistance with most of their daily activities. And again, the worse the physical functioning of the patient, the higher the death rate, shown in black, for all ages, and the higher the chance of being sent to an assisted care facility, shown in the dark grey, and the lower the proportion of people who get discharged independent back to their own home. Using large registry data, over the last year or two, there have been a number of risk calculations that have been done, and this is just one of the many. And as you can see, this is quite complex. This has been done for a European hemodialysis population based on many different things such as age, smoking, cardiovascular history, BMI, and then some biochemical measurements such as CRP, serum albumin, etc. This is a slightly simpler model that has just been published in the American Journal of Kidney Disease. Comes from Canada, and they produced a scorecard based on age, eGFR at time of dialysis initiation, and this is for both people on PD and peritoneal dialysis and hemodialysis, atrial fibrillation, chronic heart failure, lymphoma, metastatic cancer, and whether the patient has been hospitalized in the last 6 months. And the higher the score, the greater the risk of dying in the ensuing months. So moving on to how we use this prognosis in discussion with patients and advanced care planning. There is nothing complex about advanced care planning. Advanced care planning is merely communication with the patient and family about prognosis and the realistic impact of treatment. It includes treatment of symptoms, allowing time to answer questions, enabling the patient to plan ahead to achieve their goals, acceptable ceilings of care and place of care, and the discussions need to be given cultural sensitivity so that and attuned to the needs of the patient and family. And let me explain what all these mean. First of all, when should we have the discussions? There are many points in time of advanced kidney disease when advanced care planning discussions are appropriate. When somebody is having renal replacement treatment planning, particularly if they're ineligible for transplants or conservative care, shortly after they start dialysis, a failing transplant in a patient who doesn't want dialysis or is anticipated to have poor outcomes in dialysis, failing peritoneal dialysis and the patient does not want hemodialysis or is anticipated to have poor outcomes, and transplant not feasible, recurrent vascular access problems, etc. Patients who want to withdraw from dialysis after any major event which could worsen prognosis, such as a stroke, fall and bone fracture, worsening cognitive function, new malignancy, development of an intercurrent event needing major surgical intervention, increasing frailty and or cognitive decline, and the answer of no to the surprise question, would you be surprised if the patient died in the next 12 months? These discussions are not easy, and many physicians feel wary about having them with their patients. But there is evidence from randomized controlled trials, both in the general and in the hemodialysis populations, showing their value. This is a study that was done in the United States in patients who were on hemodialysis. And it was published in the American Journal of Kidney Disease. So 210 hemodialysis patients with their close person, called in this study surrogate dyads, were selected. All of them had usual care, and the intervention group had an in-depth advanced care planning discussion at the renal centre and then a follow-up session at home 2 weeks later. And the outcomes that were looked at in the study were looking at a composite of a dyad congruence on goals of care and surrogate decision-making confidence. And this was shown to be better in the intervention group. During the study, 45 patients died, and the surrogates in the intervention group had less anxiety, depression, and post-traumatic distress than the close persons of patients who had not had these conversations. Earlier on, I mentioned the need for cultural awareness when having these discussions. And it is not just the patient who may come from different culture and ethnicity to the main provider. And the patient will bring their own beliefs and values, understanding of spirituality, ethnicity, concept of health, and experience. And so will the healthcare provider, i.e. you, the nephrologist. Culture is as important as giving prognosis. Culture is an important part of context within which people understand their world and make decisions about how to act. Failure to take culture seriously may lead to problems such as a lack of trust, increased desire for futile aggressive care, unnecessary physical, emotional, and spiritual suffering, lack of faith in the physician, lack of adherence to a treatment regime, and dissatisfaction with care. So what questions and statements can we use when having these discussions? And these are just some of the ones that I use and I have found useful over the years. How is your health now compared to a few months ago? That can be a very useful starter to a difficult conversation. It is always hard to predict the future, but it would not be a surprise if some major acute event occurred or your health deteriorated significantly in the next few months. We should therefore discuss what your wishes would be should this occur. And then exploring cultural differences. Different people make decisions in different ways. Do you make decisions on your own? Do you involve your family? Or does someone from your family make important decisions for you? Have you ever thought how much treatment you would want if you are very ill and unable to communicate to make your own decisions and unlikely to leave hospital and be independent? Some people decide to stop dialysis when their health is deteriorated and they feel that dialysis has become a burden and is no longer of benefit. We don't need to mention that any further now, but it is something you may want to discuss later. This last question is often the most tricky. Patients often feel that they want to withdraw from dialysis, and I discuss this in another lecture, but they need permission to be able to open the discussions. The Renal Association in the UK has come up with some guidelines about withdrawal of dialysis, and I have just listed some of them here. So in patients who are deteriorating despite dialysis, patients struggling to cope as a result of progressive deterioration of underlying irreversible clinical problems or sudden onset of catastrophic clinical event, for example stroke, should be recognised as being in need of end-of-life care. Patients with recognised need for end-of-life care, including those deteriorating despite dialysis, should be offered the opportunity to create an advanced care plan. And any decision to discontinue hemodialysis should be made within the context of ongoing end-of-life care planning. It should be made jointly by the patient and nephrologist in full consultation with relatives and carers, family practitioner and members of the caring team. Assessment of competence should be carried out and depression may need to be formally excluded. I'm going to finish with another quote from Atul Gawande. The problem with medicine and the institutions it has spawned for the care of the sick and the old is not that they have had an incorrect view of what makes life significant. The problem is that they have had almost no view at all. Medicine's focus is narrow. Medical professionals concentrate on repair of health, not sustenance of the soul. For more than half a century, we have treated the trials of sickness, aging and mortality as medical concerns. That experiment has failed. And my final painting. This is by Edvard Munch, a Norwegian painter, and it is called Between the Clock and the Bed. It was the last painting that he did, and it's a self-portrait. Behind him, you can see a bright area. This is his life, his paintings. But he knows that he is at the end of his life. This is represented by the bed, and the clock with no hands shows that he does not know when this is going to happen. Many of our patients realize that they are at the end of their life. It is our job as physicians to be able to give them as good a quality of living over their end-of-life phase. This is done by communication, treatment of symptoms, and by being aware of their prognosis. In other words, advanced care planning. And here is a list of key references. Thank you.